Our guest today is an internal medicine specialist, Dr. Ahmet Barlak. Ahmet is also a classmate of mine from Ege University's Faculty of Medicine. For years, whether it's about my own health or regarding my patients, he's a doctor I frequently turn to for his opinion. I consult with him, and I have immense trust in his experience. Today, we'll be talking with him about diabetes, how diabetes affects sexual health in men, and the new treatment options that have emerged, that have come out recently. If you're ready, let's begin. Welcome, Ahmet.
Good to be here.
You were on call. You had a shift last night, as I understand it. How did your shift go? Let's start with that.
The shift went well. No major issues.
All right, then. Now, I'd like to talk with you about diabetes and the effects of diabetes, especially on men. Because diabetes is, I tell my patients this quite openly. It's actually the disease we like the least because it causes so much damage. When it's not managed carefully, it has the potential to damage the body, every part of the body, from a strand of hair down to your toenails. It can destroy all the internal organs. Of course, the good thing is, if it's kept under control, much of that damage can be prevented. So there's that side to it as well. I mean, it really comes down to the patient. It's up to the individual, the significant effects of this condition. I'm curious about something. Now, diabetes has, of course, always existed throughout human history. But when we compare it to, say, 100 years ago, people's access to sugar, to sugary foods was probably much more limited. So we can assume that the incidence of diabetes has certainly increased in the last 100 years. But you and I are both, more or less, right? We've been specialists for 20 years. In recent years, have you observed an even greater increase in diabetes?
It has increased in recent years, and there's scientific evidence for that. Especially in the last 40 years. In some countries, it's said to have increased 3 to 4-fold. And in general, I mean, I can give a simple example regarding our own country. In 1997, 98, a study looked at the prevalence in people over 20, and it was 7.2%. The same study was conducted 12 years later. Yes, and the result was 14%. So it doubled in 12 years. And following that, it has continued to increase. I mean, we're talking about the early 2000s at this point, and unfortunately, it just keeps on increasing.
So access to sweets, access to sugary foods, access to fruits, there are probably many factors involved in this.
Of course, those are factors, but the most important one is actually the decrease in physical activity and the rise in obesity.
Meanwhile, of course, as the years go by, our mobility, our capacity for exertion, our exertion is steadily decreasing. We drive everywhere, we take the car.
Exactly. I mean, even at home, at its simplest, you control the television with a remote.
Yes.
I mean, you don't get up to turn it on. You don't go to the button.
Right? So it's no surprise that diabetes is on the rise.
Of course, our movement is restricted everywhere in everything we do. Jobs are increasingly becoming office-based. Everything is done on computers. So it's a situation of sitting at a desk more and moving less, but we continue to eat and drink 3 times a day. And when it comes to accessing food, there's more variety, more options. Those are also factors. So when you put all these together, less movement, office environments, and along with that, there's less movement at home, less movement in daily life. And as the use of vehicles increases year by year, well, in the end, obesity and inactivity are on the rise.
So sugar consumption is increasing and our physical activity is steadily decreasing. Therefore, the rise in diabetes is no surprise.
Yes.
Well, this is a common question people ask. So I want to pass it along. For example, can a person who never eats sugar or sugary food still develop diabetes later in life?
They can.
There's also a genetic component to this.
Of course. I mean, now, there are 2 roughly known types of diabetes. You know, they're commonly known among the public as type 1 and type 2. Type 1 occurs in children. I mean, they develop it without eating sugar. Of course, the mechanism for them is different from the patient group we're discussing now. It's different.
It's different.
And similarly, in the type that occurs in older age, also known among the public as type 2, in that type of diabetes, there's also a genetic predisposition. Of course, the person's daily activities, the things we just mentioned that are on the rise, also have an effect And among these, there's a portion of people who develop diabetes even when they're thin, because diabetes isn't actually limited to just these two types. There are also types that start at an early age but require insulin, just like in type 1, which we briefly call MODY. And with them, I mean, it's as if you're looking at a type 2 case, but the patient is diagnosed at the age of 30.
So it's another variant that can also have the characteristics of type 1 within it.
Yes. And in some cases, you have to use insulin right from the start, as if it were childhood diabetes like type 1. Whereas it's neither type 1 nor type 2. There are these intermediate transitions. Also, generally speaking, there's a shift in diabetes among the population seen in studies and in followed patients, where type 1 is seen at later ages and type 2 is seen at earlier ages.
So what we used to simply classify as type 1 and type 2 diabetes is actually a disease with many variants, right? Many subtypes. Perhaps we could even say it's a disease that's unique to each individual, of course. As our old professors used to say, there is no disease, there is only the patient.
Of course. As our old professors used to say, there is no disease, there is only the patient. It's a disease that, in essence, fits that description perfectly, because the treatment is something that will be tailored to the individual. It depends entirely on the individual's lifestyle, other illnesses they may have, and how active they are in their daily life. Treatment will depend on the individual patient.
Now, we urologists can also detect diabetes from time to time. So, the patient comes to us with a severe erectile dysfunction problem. Here's the white problem. Of course, we can be a little suspicious, but when we request a blood test, whether it's for fasting, blood sugar, or hemoglobin A1C, we can sometimes find very high values. So, it's a disease that urologists actually diagnose as well. But if someone starts experiencing, let's say, certain symptoms, I'll go and get their blood sugar checked. There is a benefit to using measurement versions. At this point, you should consult a specialist again.
Now, when we look at the classic symptoms, they include drinking a lot of water, thirst, dry mouth, and frequent urination. And not by urinating small amounts frequently, but by urinating frequently and in large quantities. Start urinating more frequently at night, wake up from sleep, etc. These are the things that are less obvious, usually known to everyone, but not as noticeable, just vague. Vision deterioration begins in the eyes. Decreased sharpness. Also, occasional dizziness and a state of imbalance can occur. Psychologically, people tend to be more irritable and aggressive during periods of high blood sugar. Similarly, if blood sugar is dropping, sometimes post-meal hypoglycemia can occur in the early stages of the sugar cycle. Postprandial hypoglycemia dennis in the stage before diabetes begins. It had actually been giving subtle signs even back then.
Generally, these symptoms appear, especially dry mouth, because we don't see these symptoms in many illnesses. But symptoms like needing to urinate more than 2-3 times a night or urinating a lot and frequently. What levels can we roughly imagine blood sugar levels reaching here? So is there a mathematical basis to this?
Now, there is actually a mathematical basis to it, but it's not exact. We can even connect that to your thing. The reason for frequent urination is actually the presence of sugar in the urine. But what is considered acceptable when it comes to sugar in urine? 180 to 200 and above is considered a limit for the kidneys. Above this level, sugar starts to appear in the urine. But this isn't a definitive criterion because it varies from kidney to kidney depending on tubular function. In fact, when such a situation occurs, diabetes' own criteria apply. Diabetes itself is actually quite simple in terms of its criteria. If your hemoglobin level is above 126 twice after fasting for 8 hours or more, or above 6.5 at any time, your blood sugar test should be checked. If the level is above 200 and accompanied by the symptoms we just mentioned, then you are diagnosed with diabetes. There are more details to this as well. You know, the ones done with load tests and all that, but these are the simplest ones.
We have a group of patients whose behavior we are truly astonished to observe. So he knows he has diabetes. She received her diagnosis years ago. He has been started on medication, but who is using these medications? Even if he uses it, it's extremely irregular. You're asking, when was the last time Aliye went to see her doctor to have her blood sugar checked? Years have passed since Belkei. What dangers await these patients now, in the future? So why should they be afraid?
Now, it's actually diabetes. The sugar level itself has reached 200, or for example, it's now 250. You don't experience anything physically bad at that moment. So when the values get very high, it becomes diabetic ketoacidosis, which is commonly known as a sugar coma. But to see that, you need to look at values like 500 or 600. But normally with 200 sugars, I don't have any symptoms. I have no symptoms at all. So what's going to happen? They travel around saying this. Why is that even necessary? As you said, they mean taking medication. But that's not actually the case. The most important reason why we want the sugar levels to stay stable there, the most important reason why we want it to stay stable is to avoid complications. When we talk about complications, it all ultimately comes down to what happens inside the blood vessel. Its effects on blood vessels are also present in diabetes. The worse the sugar industry gets, the faster it progresses and the more varied it becomes.
Areas it damages most are blood vessels.
Of course, because of high blood sugar. It has harmful effects in the blood, inside the veins, everywhere the veins go.
Of course, it's not just sugar, I guess, but also a number of metabolites derived from sugar, right? So it's a team that came out of sugar. Let's call them products, byproducts, and toxic products. So sugar itself may be harmful, but the metabolites produced from sugar are even more harmful.
They have an impact too.
Now, obesity and diabetes are very closely related issues. Which one leads to the other? Let's talk about this too. So do people with diabetes gain weight? Or does a person become diabetic because they gain weight? As we just mentioned, sometimes we encounter people who are very weak, like a fox, but blood sugar levels are very, very bad. The regulation is also very, very bad. It's not always directly proportional, is it?
Of course. Now, it is scientifically known that obesity is the biggest contributor and cause of this. The same applies to blood pressure. If you are obese, your blood pressure rises. Obesity increases susceptibility to diabetes. If you are obese, your insulin resistance increases. And here it's actually necessary to look at it according to the stage of diabetes. Because in the early stages of diabetes, when diets aren't yet implemented, when obesity is present and eating habits continue, a vicious cycle is created when insulin resistance begins. Insulin resistance increases your weight gain. As you gain weight, your insulin resistance increases. One feeds the other and it becomes a vicious cycle. In fact, this is the patient group we most want to help escape this situation. Because if you can intervene at this stage, you have a chance to correct the problem before it develops into full-blown diabetes. Weight loss from diabetes itself can happen, but that's at a much more advanced stage, of course. During that period of frequent urination, we mentioned you're constantly losing sugar and calories through your urine. And as a result, there's a phase where the diabetes itself causes you to lose weight.
So that's not a very good thing, I assume, right?
It's a sign of an advanced progressing condition.
Not losing weight for 2 months?
No, it's not good. It's a sign the condition has progressed, which is a very problematic situation for us because the treatment procedures and everything change at that point. It shows the disease has progressed significantly, and those patients don't come in with sugar levels of 150 or 200. When you check them, you see their fasting sugar is in the 300 to 400s, and their post-meal sugar is around 600, you see.
Now, of course, the levels, the severity of the diabetes must also be important. There used to be a term hidden sugar. I don't know if it's still used, but
it's common among the public.
Is it hidden sugar or are they actually undiagnosed diabetics? I mean, many patients come in saying, I have hidden sugar. Are these people really diabetic? Or is it some kind of intermediate form?
Now, here's how it actually works. There's an accepted blood sugar level. This is the upper limit of normal. Then there's the level for diabetes. Anything above that is diabetes. Anything below this is normal. This area in between.
The gray zone?
Yes, in Turkey it's called hidden sugar. Medically speaking, it has names like impaired fasting glucose or impaired glucose tolerance. But really, the root of the issue is what your blood sugar level is. In the end, whether it's here, here, or here, it's all glucose. It's the level of that glucose. And what's the average trend? That's really the whole issue. That's why, for us, whether someone has hidden sugar or has returned to normal levels doesn't really make a difference. In our treatment approach, right from the start, we'll discuss this in the treatment section, but there are things that need to be done. Steps that must be taken from the very beginning. We actually start those right at the point people call hidden sugar. That's when treatment needs to begin. But ultimately, what's the root of the problem? The amount of sugar in the blood. When your sugar starts to rise, you should know that it's a risk for you.
When the higher it goes, the greater the risks.
Of course.
So, in which patients do we feel the need to screen for complications caused by diabetes? For example, in the initial stages for a diabetic patient whose hemoglobin A1C has just passed 6, is it necessary to perform very serious screenings right away? Or is there a threshold for that as well?
The accepted approach is actually somewhat related to when these complications appear. Normally in diabetes, there are two things. One is a disorder affecting the large vessels, and the other affects the small vessels.
Yes.
To put it simply, what we call macro and microvascular complications. Now, the part related to the involvement of small vessels, which is the part that concerns you, falls into that group.
Yes.
And it usually appears after about 5 years, but that's an average figure. Some studies have shown that even at the time of diagnosis, when diabetes is first identified, 20 to 30% of patients can already have these small vessel disorders. Of course, this is related to access to testing in different countries, how easily tests can be done. I mean, ultimately, yes, we live in a big city now. Here, patients can easily go get tested and have these things checked, but not everyone everywhere has this opportunity. Now, if someone gets tested every 5 years and becomes diabetic 1 year after their first test, they might only find out 4 years later. So for that reason, there's a possibility these things can be present right from the start, even at the time of diagnosis. Now, when these vascular problems start to appear, a decision needs to be made based on the patient's condition and their sugar levels. As I said, it's roughly 4 to 5 years, but if you've seen a case with a delayed diagnosis from the very first day, you need to check if there's a kidney problem, if there's a problem with the vessels in the fundus of the eye, or if there's a cardiac issue. These things must be checked.
There's no harm in checking.
Of course, there's no harm in checking. I mean, if things are going well, then fine. After 4 to 5 years, these things should be looked at in detail. But in a case you've caught late where you don't know its history, it makes no sense to say, let's wait 4 years for these things.
There's also a condition called neuropathy. I believe it has symptoms too. Numbness in the feet, right? Tingling sensations.
Numbness in the hands and feet, feeling cold, loss of sensation, tingling, burning.
Is this also an indicator that things have progressed? I mean, for other complications as well, right?
Of course. This also falls into the group we call small vessel or microvascular complications. Neuropathy, retinopathy in the fundus of the eye, and nephropathy in the kidneys. It happens. Similarly, that group also includes erectile dysfunction, erection problems.
Erectile dysfunction in diabetes seems to be a common problem. It's something you encounter frequently, right?
It's actually quite common. I mean, although it varies depending on, of course, it's also related to how much people report it in these studies, but it's seen in approximately 40 to 60% of cases. Especially, of course, the rate increases with poorly controlled sugar levels.
As the severity of the diabetes increases, so do the complications.
Of course.
And one of those complications is erectile dysfunction. It's generally said that the problem of erectile dysfunction in diabetics is seen 3 to 4 times more often than in the non-diabetic male population, even within the same age group. Moreover, diabetes also damages the vascular structure and the nerve structure. It also affects the hormonal structure. It affects hormone levels, so it causes damage everywhere at once, doesn't it?
Of course.
That's why we see erectile dysfunction at an earlier age and with greater severity.
These types of problems appear earlier in terms of age compared to non-diabetics. And also, from our perspective, since it's a microvascular complication, and in fact, one of the earliest things to deteriorate in the body, well, from our point of view, when we're discussing whether to screen for complications, the presence of such a complaint immediately suggests to the doctor that, yes, the complication stage has begun.
And I suppose we actually have to ask, because some patients, right, might be hesitant to mention it.
They might be shy and not say anything. So it's good to ask in a way that makes them feel a bit more comfortable.
Yes, and if it's a progressively worsening erectile dysfunction, it might be necessary to be more careful with their sugar levels or to monitor them more frequently. Now, this phenomenon we call latent diabetes. We just talked about it, but let's go over it again. So, diabetes, even when it's in quotes are mild, meaning when it has just started, can still cause harm, I suppose, right?
Of course.
I mean, that's not the case. You know, when patients say, I have a little sugar or my sugar is just a bit high, that's also a dangerous situation.
Yes, of course. During that intermediate stage we just showed, which people call latent diabetes, complications and deterioration actually begin in both large and small vessels. And these vascular problems, as I said before, at the time of diagnosis, 20 to 30% of patients already have small vessel problems, the ones that are supposedly late to appear. So when did this happen? This happened during the period you call latent diabetes. For that reason, the same way it applies to the kidneys, the same way it applies to the eyes, it also applies to the penis. The control of kidney functions, the control of the eyes, while these are being checked, this should also be asked about. And this should be asked about in the early stages, because if these things have started in the early stages, then for this patient, perhaps, as you said, in the period when they say, I have a mild case or I have a little bit of sugar, it's not a big deal, they might actually be missing the periods when their blood sugar is high, since they don't know their continuous blood sugar measurements.
Of course, that's a possibility too. So let's say a person is diagnosed with diabetes, but they start to pay close attention to their sugar levels. They take their medications regularly, do whatever is recommended, attend their checkups, and the checkups confirm that things are going well. Then there's no problem left. In that case, can the body repair itself? I mean, these micro complications caused by diabetes, of course, do they also tend to improve over time?
Well, that actually depends on time and how long things went well versus how long they went poorly. If there's uncontrolled diabetes from the start, and this uncontrolled diabetes has gone on for, say, 5 or 10 years, then these complications become more permanent.
If it's really set in, right?
Yes. The earlier you catch it, and if the patient becomes aware of the situation and really does their part, their diet, exercise, what we call lifestyle changes, and does them properly, takes their medication correctly, goes for checkups and gets the necessary measurements when needed, and manages it well, then things will go that much better. And what happens then? You catch the complication earlier, and you can map out the course of action, whether it's medication or something else that needs to be done. After all, I'm an internist. So if there's an issue with the eyes, I refer them to an ophthalmologist. If it's related to erections, to you,
A urologist.
if there's a heart problem, to a cardiologist. That's how we arrange things. Proper follow-up is what allows us to head these things off early. But with diabetes that has been poorly managed for years, recovery is, of course, if it's already taken root, it's a bit difficult.
So with an early diagnosis, it's possible to recover.
Of course.
The body has its own repair mechanisms after all. And with the efforts of medicine, of modern medicine, some things can be regained, some functions can be recovered. Okay, so at this point, should we just rely on diabetes medications or insulin? Or are there things our patients should do, things they should adhere to? You just mentioned lifestyle changes. What are they? I mean, what should they strive to, what should they try to adhere to? Because diabetes medications alone may not be enough. But when you combine them with other things, right, you get better results.
Of course. In fact, in treatment, the number one medicine is lifestyle change. I mean, of course, they need to see it that way. It's not just, I have diabetes, so I have to take this pill, or I have high blood pressure, so I'll take this blood pressure pill. No, the first medicine is this. First and foremost, they need to do this because, well, this has been proven by studies. It's really effective at lowering blood sugar, during the insulin resistance phase, before it becomes full-blown diabetes, during what we call the latent diabetes period. For example, there's a medication we use in that period called metformin. It's even more effective than that in preventing the progression to diabetes. A proper diet, exercise, and losing excess weight, if any. Roughly speaking, there are actually 4 rules. Of course, there are details. First, you'll have to learn how to eat a diet suitable for diabetes. You have to learn it.
I guess that requires some discipline.
Yes, you have to learn it. Second, you must have physical activity, exercise. Third, if you have any excess weight, you will lose it. Now, as we discussed at the beginning, a person can also be thin. So if someone is thin and not overweight, does that mean they don't need to diet? They also have to learn to eat for their diabetes.
They're separate concepts.
They'll learn to eat for their diabetes, but someone who is overweight will manage this by losing weight. And of course, you have to quit smoking.
That's inevitable in any case.
So basically, in the simplest terms, these are the 4 rules. They have to follow them.
Because that affects the blood vessels.
Of course.
And it can cause an effect like 1 + 1 = 3, right?
Its direct effect is clear. I mean, its impact is so well known, there's no need to even say it. That's why with classic lifestyle changes after developing diabetes, or even before, during that pre-diabetes period, these 4 rules must be followed, and they are truly very effective. So this isn't just some approach where every doctor says, lose weight. It's actually been scientifically proven how effective this is.
It can also reduce the need for medication.
Of course.
It might even allow some patients to stop taking them.
In some patients who lose a good amount of weight, they can sometimes be monitored without medication for a period.
Okay, so let's say we've been diagnosed with diabetes. Does life just stop for us? I mean, are we never going to eat sweets again? Are we never going to eat ice cream, doctor? Are these things forbidden for life? If I were to ask you this in layman's terms.
Well, they're not forbidden for life, but it's not like you can eat them freely either. Of course, this is about managing your diet. When you have those carbohydrates, it's about what you remove from your regular meal to compensate for them. Because at the end of the day, it all comes down to how many calories you consumed, how many you burned, how much of it was sugar, and how it affected your blood sugar. So, of course, from time to time, a person can eat small things, just enough to satisfy a craving. Of course, it also depends on what you're eating. I mean, things have changed now. It's not just, say, a sugary baklava like in the old days. There are also diet-friendly versions made with sweeteners.
Those can be preferred, of course.
I mean, there are versions made without pure sugar. The same goes for jam. After all, what do we make it with? Sugar. There are also versions we make without sugar, using other things, and so on. So you can lean more towards things like that. The diet can be adjusted accordingly. In small amounts, of course, as long as it's not too much.
A small slice of cake at a birthday for a close relative, a grandchild, or a child, right?
Of course. Maybe that's okay.
But you probably shouldn't be too insistent with someone you know is diabetic. In our culture, we have that, there's always this pressure. Go on, eat it, what's the harm? But that's not how it works. And I suppose you shouldn't break that discipline. Another one of the questions we get is, Doctor, I started taking diabetes medication and my erection problems began. Is there any scientific validity to this? I'm asking because I don't think there is, but it's a question we get asked a lot.
No. Normally with diabetes medications, there's no significant data that says you'll see a certain percentage of erectile dysfunction with a specific drug.
Yes.
Actually, all of those issues stem from the diabetes itself, as we explained at the beginning.
I guess there's also a reserve, right? When a person's reserve is depleted, right? Problems start to appear one after another. I mean, many systems that were managing until that point,
of course,
once they start to break down, the problems just keep coming, one after the other. And then there's this, of course, there's a common belief that diabetes makes you irritable. I mean, are diabetic patients really more irritable, more aggressive, more angry?
That's also related to blood sugar. I mean, we see this in people with very high blood sugar and also in those who experience some hypoglycemia. Especially, everyone feels it from time to time, this feeling of hunger. You crave something sweet, for example. If you say something to them at that moment, something that would annoy them, they'll give stronger answers, stronger reactions than they normally would. Actually, that's the state you're in during that hypoglycemic moment. So with diabetes, this situation can happen due to high blood sugar. But also intermittently when the patient becomes hypoglycemic, for example, by skipping a meal, which is what we see most often, like taking their medicine but not eating their meal. In situations where they skip a meal during those hypoglycemic moments, the patient can become irritable, a bit aggressive.
So it's generally related to low blood sugar.
It happens with that, and it also happens with high levels. But it's not about the sugar being normal. It's either going to be really high or a significant hypoglycemic state.
And I guess some people might abuse this a bit, right? I mean, they have a tantrum saying, I have diabetes. So I guess there are cases of faking it too.
Of course, they hide behind the phrase that diabetes makes you irritable. They add it themselves.
They get a secondary gain from it or a way to express their anger, and they might want it to be tolerated by other people. In this case, it's best to be conscious of it. I mean, I guess there's no need to have such tantrums.
No need at all.
Another important topic. Recently, these weight loss injections have become very common, of course. They've been in the media a lot. As far as I know, these are actually at the same time, not just for losing weight. They are also diabetes medication, a diabetes drug.
Officially, they are all diabetes drugs.
That's their intended use. Now here, of course, there's an indication for some patients, for diabetic patients. This is important. I guess internal medicine doctors make this decision by talking to the patient, weighing the pros and cons. Who exactly should use them? Or perhaps even more importantly, who shouldn't use them at all? As we just said, for example, could a very thin diabetic patient, for instance, face much worse problems or complications if they use these?
Now, in that regard, there's something to consider. First, if a person is obese, that's a step towards us recommending its use. Ultimately, these drugs have two official indications, the ones currently on the market, both for diabetes and for weight loss. So officially, it's a weight loss drug, and officially, it's a diabetes drug. Now, unfortunately, in society, there's this mindset of, I'll just get it, use 2 boxes, lose some weight, and then stop. That's the common approach, but the reality of their use isn't like that. And indeed, for diabetic patients in type 2 diabetes, this drug is used regularly. It can even be used together with insulin.
It reduces other meds.
Of course, it's adjusted accordingly. Of course, a doctor needs to manage this, because when you start it, other medications might need to be reduced, changed, or decreased depending on the patient's blood sugar. Then over time, the patient will lose weight by using it. And when they lose weight, their blood sugar will drop. When the blood sugar drops, the treatment will need to be revised again.
If they're using insulin, right, their doses need to be changed?
Of course, their doses will need to be changed. That's why these things must always be done under supervision. For this reason, we have patients who have diabetes and use this type of medication, and we get very good responses. But it must be done with follow-up, because it's not like those who see others using it for obesity, use it for 2 months and then stop. Ultimately, this is a diabetes medication. Just as you adjust a medication based on a patient's blood sugar, when these are added, an adjustment must be made accordingly, and there are follow-ups and necessary tests. These must be done.
So you can't just start and stop on your own without any help or support?
No, you can't.
In fact, it's extremely important, because if you're also taking other diabetes medications alongside it, I suppose it has the potential to affect many systems.
Let me add a small point here. Generally, people with diabetes on this topic, they're a bit like those I mentioned earlier who use it for weight loss. They ask me, for example, how long should I use it? Now, there's no such thing as a set duration here. Just like how you take a blood pressure medication or a diabetes medication regularly after starting it, as long as there are no side effects or it's not becoming ineffective, this drug is also meant to be used regularly. So it's not a situation where you bargain for 6 months or 3 months from the start. It's an official diabetes medication. You use it. The doses are adjusted according to your blood sugar, and it's used that way. So it's actually beneficial for people to understand the difference between its use in diabetes and its use in obesity. Because that regimen, unfortunately, isn't just, as I said, I used it for 2 months, lost weight, and then stopped.
These are all separate professional topics, really. They are absolutely not decisions to be made on your own. Of course, we're saying this for our patients' health, because once you mess with the body's settings, it can sometimes be quite difficult to compensate for that. It's important to be careful. And of course, these are very serious matters that require decisions to be made by consulting, meeting with doctors face-to-face, and getting an examination. Thank you very much. Thanks for coming.
Thank you.
I hope we can talk again on another topic. And by the way, while we're sending our greetings to everyone, we'd especially like to send our love and respect to the EG TUP 2000 graduates from here.
Greetings, everyone.
Hope to see you again.